go into that. That's our first show.
If I believe there's a reason for this pain I'm going through, if I believe that leaving me was all that you could do, if I believe that I can feel you by my side, I'll make it through the night. If I believe that time will teach me how to find my way, if I believe that broken hearts grow stronger every day, if I believe that now you're dancing across the sky, I just might get by. If I believe that memories won't always hurt this much, if I believe that I will see your face again, I can wait till then. If I believe I'll hold you in my arms again, I can wait. I know that I can wait. I can wait till then. I can wait till then.
Hi, my name is Joanne Ravicchio, and welcome to the Somerville Overcoming Addiction Show. Our special guest tonight is Dr. Ellie Grossman. I was reading a little bit on your bio that you're been, I don't know how long you've been in practice, but you graduated 18 years ago from medical school. And the one thing that I did read is that your specialty happens to be addiction.
Yes.
Which is great. So I'm going to let you give us some input as to what you do on a daily basis, and I'm sure that you have a lot to fill us in on.
Yeah, so thank you for having me here. I've been working here in Somerville for about 3.5 years now, and have really gotten to love this town. I'm trying to talk my husband into moving here. So what do I do? I'm a doctor. I trained in internal medicine, which is a fancy way of saying general medical practice for grown-ups only, not kids. And then along the way, I kind of picked up an interest in addiction. It was something I saw a lot of at the hospitals where I was training, and found it both really very interesting, sometimes really sad and disheartening. but also fascinating because we don't know that much about it. And so over the years, kind of steered my practice in a way that's allowed me to work with patients with addiction, work building health systems that provide better services for patients with addiction, but also stay kind of true to my background as a primary care doc. So if I were to meet somebody on the street or at a party or whatever, and they say, hey, you know, what do you do? I will say, first and foremost, I'm a primary care doc.
So I'm sure that you probably have a lot of times that people will ask you what they can do for their children or themselves if they do have addiction, which is a great thing. I know that when I go out there and I'm with people and they know what I do here, they always will open up to what's happening in their life.
Yeah.
Yeah. Do you find that a lot of people are embarrassed or ashamed?
Yes. Less so now than a few years ago, because you can't help but see all the stuff in the lay press about the opioid crisis. And everybody knows somebody who's had a friend or family member affected. And yes, so when I say, oh, I'm a primary care doc, and I also do addiction medicine, inevitably people will say, oh, that's really interesting. I've heard, or I know somebody, or whatever, because it's everywhere these days.
It is. I mean, I remember when I first saw Anonymous People, they quoted as being 80% of the country is affected by addiction. And I get a feeling that it's a lot higher now, you know. And of course, there's about 200 people dying a day, and one of them was my son. You know, we're coming up on a 10-year anniversary on November 15th of 2009. And remember, we were talking a little bit earlier about, you know, there wasn't enough services, and I don't think that a lot of them understood it, you know, as much as they do now.
No. Certainly the medical culture has changed and grown dramatically and continues to. I mean, I trained in the early 2000s. I trained in that era we talk about now as, oh yeah, back in the day, we used to say, if you had pain, you couldn't get addicted to those medicines. And now we kind of scratch our heads and say, whoa, what were we thinking? But that was the world I trained in. And there's medicine, like any other field, that we may not like to admit it that much. We do things because this is the way we learned it from the people who are teaching us.
Right.
And we like to think that we read the new science and we ask questions and we do things based on science and evidence. But the reality is that a lot of what we do doesn't have evidence, and so we just have to do with whatever is in our gut or whatever we've learned from the people who we're training from. And back when I trained, which is when a lot of other healthcare providers trained, the thing we did was, oh, if you're having pain, tell me. It is the fifth vital sign. We will ask everybody if they're having pain. And if you're having pain, we will do something, and that typically involved giving a medication to get your pain level to 0. And that...
I always wonder, when did that occur? What's your pain level between 0 and 10?
Yeah, no, I don't know when it started. What I can say is certainly by the mid to late 90s and into the early 2000s, when I was going through my training process, that was what you did. And actually it was, and you were told to do it more and more. I mean, we were told, whether it was medical school or residency, we in the medical profession have a history of undertreating pain. Now we know better. Now we know to measure it as the fifth vital sign, and now we're going to treat it. And that was one swinging of the pendulum. Now we're somewhere different. Maybe we're swinging too far the other way, and that there are medicines that have risks like opioids, but they do have a place in treatment for some people with some conditions. Some would argue we're swinging too far to the, we're not going to talk about pain, we're not going to treat pain, we're not going to use opioids ever. Probably where we need to be is somewhere in the middle, where we have a compassionate and thoughtful approach to people having pain and offer them treatment that involves medicines, maybe not necessarily opioids, and other things that we know actually work. But back when I trained, it was about opioids, and we were told, like, oh yeah, if they've got pain, this is not going to be a problem for them.
Right. Which, you know, I thought originally an OxyContin was made for people that were dying internally of cancer. Mm-hmm. You know, and to me, I can understand using such medicines because you don't want to see anybody suffer. I've seen people suffer with cancer, and it's like, please help them. Even when Frankie had a motorcycle accident, and that's when his addiction started, when he was 21 years old. I was there at Mass General, and I worked right up the street at Verizon, and I worked the 11 to 7 shift. Needless to say, I didn't get to work that night. I stayed with him for almost 2 to 3 days, and, you know, and I was actually telling them, please help him, because you're seeing them suffering, and you don't want to see them in pain. But if I had known that, you know, that OxyContin would eventually, you know, become a huge problem in my life and my family life. You know, it was a 10-year struggle in and out of detoxes, and, you know, unfortunately, it's like he didn't like pain.
Right.
You know, so if he did, he would do whatever he had to, and he actually put a needle to his arm. It got to the point where he went to heroin. So, you know, let's discuss. So, is your practice open to new?
Yes. I will freely advertise.
I think that's great. She's taking on new customers.
So my clinical practice is at Cambridge Health Alliance in our Somerville Hospital primary care site, which is at the Somerville Hospital on Highland Avenue. And that's where I see patients. I also work with, teach, supervise, et cetera, medical providers and other staff at all 13 of our CHA primary care sites. And so while I'm open to new patients, my other colleagues at our Somerville Hospital site are open to new patients. I'll also say we're open to new patients at, I think, all of our other sites. And at this point, I can say all 13 can offer treatment for opioid use disorder. We didn't used to be able to say that, but we now can. Currently 12 of 13, no, excuse me, 13 of 13 are offering buprenorphine, otherwise known as Suboxone. And 12 of 13 are offering Vivitrol, otherwise known as extended release naltrexone. So yes, we at CHA want to help people with this condition, and we are ready, willing, and able to do so.
I think that's really wonderful. I've seen a big of change in the past 3 or 4 years. You know, I think ever since I was at Somerville City Hall at a public health meeting, and I was there with Mary's here in the audience. You can say hello, Mary.
Hello, Mary.
Well, anyway, we sat there and we talked to Mark Albanese, and at the time I had said, you know, a lot of I waited till the end, you know, and I said that I was a parent that lost a child to addiction. And the one thing that I was concerned about was how they were being treated in the emergency room. And I felt that it was horrible. You don't know how many times I just wanted to climb over the bed and say, and shake them and say, you're treating my son horribly, and I don't appreciate that, and I've seen a big difference. And I said at the time, could we have some, you know, sensitivity classes maybe? It's just that sometimes when, it's just like any profession, and not just the emergency room or in the hospital, but it gets to the point where people unfortunately judge and they put you in categories. And the same things happened in schools, you know, when the child that speaks out and, oh, he needs help, he needs you know, an IEP, he needs, you know, he has ADHD, you know, and the thing is that I just wish people would take them and each person as an individual and not put them in categories. So I've seen a very, very big difference in CHA, and I'm very happy that you've improved your services to people of addiction.
It's been something very important across the institution, in our Department of Psychiatry, in all 13 of our primary care sites. It's a service we've been working to normalize and destigmatize even within our healthcare settings, because we know these are things that are tough for people to seek care for. They are tough to disclose. And yes, we in the medical profession certainly have not always treated people with addiction particularly well. But it's something we are have worked and continue to work very hard to change. And because one thing we're aware of is addiction is a chronic disease. It's going to have tough times. It's going to have less tough times. People with the condition are going to have less challenging times. And we take the long view. We're not here for our job at Cambridge Health Alliance. We're not here for the 3-day detox. You're one, you're done, you're out of here. We don't care about you anymore. Not to say that detoxes necessarily take that attitude, but we hope, want, expect to be taking care of our patients, our towns, our communities for the long run. And so that means you need intensive treatment now, whether that's inpatient or outpatient. We're going to help you get that. We hope that over time you're going to get better and you'll need less support from us. And maybe that means that you just need to see your primary care doc and check in now and then. And then there may be other times where there's some stressor, something changes. Maybe we can't identify what it is that changed, but you need some extra help. We're going to be with you for that too. And so we're really trying to pay attention to all the nooks and crannies of our healthcare system so that we're all ready to help and treat this like the chronic condition it is.
It is, yeah. It's wonderful to hear you speak of it and what you'd like to see. She definitely knows what she's talking about, that's for sure. And I want to thank you for caring that much about the people that need your help. And, you know, let's face it, I mean, if past 4 or 5 years, you know, things have changed on how addiction is handled. Because now you're learning more about it, you know, and it's great to change and try to improve the system. You know, it is a huge, huge problem. It's an epidemic that, you know, there's 23 million people using and in trouble. And there's 22 million that are in recovery. So hopefully we can raise the numbers and have more in recovery, and that they don't have to die. Let's get, you know, give them the services that they need. And like I've always mentioned, that they have their own stigma. They don't need anybody else's. So when people are kind and helpful, that makes them feel a little bit more comfortable about what's going on with them. Poor Frankie, I mean, it was a 10-year struggle. He even went and got loans from the bank to be able to help take care of his addiction. You know, the poor kid, he suffered really. And being a parent, you know, anybody that's close to someone that's using, you're just as devastated as they are. So sometimes your families end up walking away because of things that have been unsuccessful. The 50 times that they've been to the detox, or you know, not only, but relapsing too. You know, I've been there with 2 children, and it was a tough. I would love to have just gone to Disney every year and have this wonderful life, you know, raising your children and bringing them everywhere. But then all of a sudden you have addiction. It's like you never get to go away again. Even when I would go away, I would like worry about what's going on at home. Is this going to be the day that I find my son? You know, which did come, and it was not a very easy time for me. At least 24 years of addiction out of 65. You know. And hopefully now, you know, I'm enjoying my grandchildren and my son and his fiance. You know, it's nice to be able to see something normal again.
Yeah.
You know, and I love it. I love it. And it's people like yourself that help that happen.
We try. As I'm sure you know from experiencing this as a family member and as a friend, it takes a village.
Right.
And people who are living with addiction and the people who are living with the people with addiction, it's not a situation they got into that happened overnight. And it's not a situation that's going to change on a dime overnight either. And so actually a lot of my work, or one piece of my work that I think is important, that especially as I think about talking to family members, and I really encourage my patients to bring their family members with them to visits. They're usually scared to, and I also understand there are things they may want to, they tell me and they don't want to tell their family, and that's okay. Because I do feel like an important part of my job and the healthcare system's job is to help families understand that this isn't something that can be turned on a dime overnight. This is going to be hard. This is going to take work. But hopefully we can kind of build a village of support around you all so that at least you don't feel alone in it. And again, maybe that might mean community meetings, support groups for family, for friends. It could mean coming to healthcare appointments together. It's going to be different things for different people. But there's a history in some parts of addiction treatment where I think we haven't done a great job of setting people's expectations appropriately. You know, because there are these stories of people, especially say with alcohol, where, you know, I saw the light of God and I stopped drinking, or I went to AA meetings and I stopped drinking, and why can't everybody else just do that too? And the reality is, if you're living with addiction, the odds are pretty good you're not going to be able to turn that around all of a sudden all by yourself. You're going to need help from others. Who those other people are, I don't know. But we have to help the person with addiction understand that they're going to need help, and that's okay. And we have to help the people around them understand that they can help, but that it's going to take time.
I remember the first time, actually, Frankie asked me to have him sectioned because he wanted to stay longer. And at the time, the detoxes only kept you for a small window of time. And until the bill went through that insurance companies in Massachusetts have to pay up to 14 days, people didn't know that. They still don't know that.
Right.
Even though we're trying to get 28 days, I remember that. Yes, maybe 3 to 4 days is what you need for your body to go through withdrawal from the opioid, but it takes a couple of years for your mind and your body to what is it? Get
Catch
over
up.
Yeah,
I mean,
catch up.
I use the term today with a patient, brain training is as you're entering recovery, you are now experiencing feelings and thoughts, but especially feelings that your brain and your body haven't let you experience before. That's really scary.
It certainly is.
And really hard. But again, just takes time and the confidence and support to know that I've got people around me who are in this too.
Right. They need support. They need your help. It's not, like you said, it's not overnight that's going to happen. I remember talking to a friend, and I talk about this a lot, that he was in detox, and they said to him, "So what's your plan?" And he looked at them, he says, "My plan got me here." So a lot of times, they're going to need the support of others. Yeah, as a recovery coach, you're going to give suggestions as to different routes, but you're not going to tell them what to do. And that's the problem that happens. You're going to do this, and that's how you're going to handle it. You know, you have to give them the option of how they're going to handle their recovery. And hopefully they will, you know. I see a lot of success. Some people do well with just abstinence. Some people do well with treatment. Out of the two, which one do you think that you'd like to see them do? Is it Vivitrol?
So in general, when we're talking about opioid use disorder, and it's different if we start talking about other addictions, but if we're talking about opioid use disorder, in general, what we know is people do better with medicine than not with medicine.
Okay.
And then, so if we say, okay, generally I'm going to nudge somebody towards medicine, then we've got 3 medicines on the table. We've got methadone, we've got buprenorphine, Suboxone, and we've got extended release naltrexone, which goes by the brand name Vivitrol. And we don't have really a lot of evidence, science, saying that one is better than the other. In general, our science would say, on average, they work about the same. But they're very different experiences of how the medication is given. And so you can kind of lay it out for people about what sounds like something you want to try. And I may have some ideas about what is going to be best for somebody, but if they're not bought into the idea that this is what I want because I'm in control, it's not going to stick. So methadone, as many people probably know, it is offered when it's used for addiction treatment. It's offered in what most people refer to as methadone programs or methadone clinics. The official term is opioid treatment program, so some people in the field will use the acronym OTP, but mostly people know them as methadone programs. In our area, North Charles, based in Cambridge, is probably the one I've used the most, but there are a number of them in our area. And the advantage to that is it's got a lot of structure. You got to, for those first few weeks and perhaps months, you are going somewhere to get your medication. You have to have eyeball to eyeball contact with somebody who's saying, "Hey, how you doing today?" And it's sort of a daily, for some people it can be really a daily affirmation of, I'm getting up this morning, I'm taking care of myself, I'm going to go see my counselor and go get my medicine. And that structure can be really good for people. And most methadone programs have early morning hours, some have evening hours. I mean, so it is possible to have a job or have family childcare responsibilities and go to a methadone program. That is the goal. That said, methadone has a lot of stigma, probably more so than the other two medications in the current day. And you could say that's may not be deserved. That methadone actually has a very good place in our treatment armamentarium. But many people are not excited about the idea about that as a first-line option. Kind of takes people some time to get used to the idea that, maybe I do need that extra help that the methadone program is going to give me. What's an option with less structure is going to be buprenorphine or Suboxone, which you can come to see me in the primary care office. No one's going to know why you're coming into my office because I see people for diabetes and high blood pressure and pneumonia and coughs and cold and all that other stuff. You come see me. I see you behind closed doors in a room just like everybody else. And you're going to get a prescription and you're going to go fill it at the pharmacy. And yeah, I guess the pharmacy staff is going to know what they're filling. And certainly I have heard stories about people not being treated so well at the pharmacy. Again, less of that these days than there used to be. But typically when I or most other providers are seeing someone for buprenorphine, Suboxone, we'll see somebody once a week at the beginning, maybe more than that if we can. And then the visits may stay once a week for a while, and then typically it'll get to be once every couple weeks, once every month. But it's not the everyday eyeball-to-eyeball contact you get at a methadone program.
Can I ask you one question?
Yeah.
What if someone wants to get off of methadone? How would they do that? Of course they do it with their doctor.
Right.
Is it a long, lengthy procedure?
So like anything else about healthcare you ask me, I'm going to say it depends.
One size does not fit all.
Exactly. No, and any healthcare provider who says it does is not one I would trust so far. But so again, with methadone, because methadone programs are highly regulated, both at the federal level and the state level, if someone makes a decision to say, okay, I want to taper myself off of methadone, then basically what happens is you have a conversation with your counselor at the methadone program, and together you come up with a time frame, and your dose is going to come down bit by bit. And assuming that this is something that the patient, the client has initiated, they're in control. They can say at any point, hey, I think I'm okay with my dose now. Let's stop the taper. I'm okay staying on it for longer. Because when you taper off of methadone's an opioid like heroin or fentanyl. And so when you stop taking it, you're going to have some withdrawal symptoms. And in general, if we bring down the dose slower, you'll get less of those symptoms because your body kind of has time to acclimate. But at certain points, you may have more symptoms. And again, sometimes we can manage those symptoms with, say, ibuprofen for aches and pains. But there may be times where, I don't know, it's holiday season and you want to just enjoy life with your family and not worry that your aches and pains are going to act up because your methadone dose is coming down. So you could slow down your taper. And it's the same thing if you were to tell me you wanted to taper off buprenorphine, Suboxone. In general, we know people do better if they taper off it slower rather than faster. But there may very well be points when it's hard, or they say, I think I'm okay at my dose where it's at. I don't want to rock the boat right now. Okay. The message I actually do want to say loud and clear, though, people ask me a lot about coming off these medicines, tapering these medicines. What we know from science so far about this is when people come off of medication for opioid use disorder, and really this is methadone and buprenorphine, because we don't have all this evidence for Vivitrol, because it hasn't been out that long. But we know when people stop methadone or buprenorphine, their risk of relapse will go up. It may not go up sky high, but it is going to go up. And I'll tell my patients that if they ask about, hey doc, can I come off the medication? I'll say, in general, your best shot at not having a relapse is to staying on medication. If you really want to come off, though, that's fine. We'll come up with a schedule about bringing down the dose, and we'll figure it out. But it's not generally something I recommend for anybody. And the people for whom I am most supportive of it are those in really quite solid recovery. And that may mean, duration of time in recovery. It also means how well their life is going. Do they have a job? Do they have some productive way they're spending their time? Have they had their other mental health conditions dealt with? All that other stuff. Because if that other stuff isn't stable, they're not going to have a good time coming off that medication.
Absolutely. A lot of times a lot of people self-medicate. They self-medicate without liquor because they're not able to deal with what's going on in their lives. Mm-hmm. Like you said, mental health issues, which now we have dual diagnosis. Mm-hmm. So if you don't take care of the mental health part of it, mm-hmm. how are you going to be able to deal with coming off of or getting assistance mm-hmm. to your opioid mm-hmm. issues? So, but at least a lot more is happening out there, and I'm very proud to see that, we're doing the best that we can to help people with addiction and not having stigma.
Yeah.
Although we still have a lot of it out there,
yeah.
But in our community, all I say is that if we all work together, we can accomplish anything. And the thing is that sometimes it is the communication part of it that people don't know. And that's why I do what I do. I want people to be educated as to what's available to them in their city. Mm-hmm. And I'm thankful that you came on.
Oh.
Yeah. And I look forward to having Randy come on as well. You explained everything in detail, and that's good. So hopefully they won't be confused about, the services that you provide. And it's great that you have an open practice, so it's not like you're just the doctor giving them a prescription, medical treatment for the opioid. Everybody's there, and that makes it a lot easier. Just like, there's certain other things that I would love to see happen, like some will have a recovery court system, yeah. Which is not going to happen soon, but I want people to, I would like to have them separated from, it's the only time I would like to see anyone of addiction separated from the rest of the court system because of their own stigma. They want to have them have a specialty, like the judge, Roanne Spargo. She's wonderful. Mm-hmm. And she treats them with dignity, and that's what I feel that you do. You're not judgmental. You're helping them, and that's what they need. They need more people to be more caring. Yeah.
We're at Sage, we're almost at the point. We're not there yet, but we're almost at the point where we can really say we take care of this like we take care of any other health condition. We don't do it perfectly. We don't do anything perfectly.
No one ever does.
Right. I'd be lying if we did, if I said we did. But we're working to there. And just as of last week, launched a program so that in all 3 of our emergency departments, so Somerville, Everett, Cambridge, if someone with opioid use disorder comes in, if it's appropriate, the emergency room provider can start them on buprenorphine, Suboxone, in the emergency department. And whether or not they get medication from the emergency department, they will get hooked into one of our addiction nurse case managers who will reach out to them within, where our target is 24 hours. The Friday night over the weekend time, we're not making the 24-hour promise, but it is our goal. But the idea is anybody with addiction, and especially opioid use disorder, who hits one of our emergency departments, if it's appropriate, we're going to get you on medication there, and we're going to get you set up with one of our nurse case managers who can help link you to whatever is the next best place for you to get the ongoing treatment. Because I said all of our primary care sites offer treatment for addiction, but it's different at different sites, partly just because schedules of different doctors, obviously just the geography. People want to go to Everett, people want to go to Somerville, people want to go to Cambridge, Malden, wherever. But also some of our sites offer treatment in groups. Some have both one-on-one doctor-patient time and groups. Some don't have groups at all. And so again, we can try, because all of our sites are a little different, our nurse case managers can really help patients find the place that's the right fit for them, which might change over time, because what someone thinks they need as they enter treatment may not in fact be what they need as they get to know themselves and their healthcare team gets to know them. But we have sort of several hops people can take as they figure out that road of recovery.
That's wonderful. It's so nice to see that we're always striving to improve ourselves. And that's what I see with CHA. They have constantly looked at every area and have improved. Mm-hmm. Don't you think, Mary?
Oh, absolutely. In fact, I was hoping you would talk also about the expansion of the recovery coach services, introduction into the Cambridge emergency department, and then in Everett, where actually Everett is our busiest emergency department. But
yes, no, exactly. And it is good to have the nudge from Mary Casesso here. So, so recovery coaches, we've had them in Everett Hospital, both the inpatient side and the emergency department, for a bit over a year now. And yes, as of this month, expanding their hours at Everett and expanding their presence to Cambridge Hospital site also. And because what we've realized, it's actually been interesting, their effect on our system, because the obvious one is they're a different way for a patient to link into treatment. You know, just a different way to make human contact, a different way to get support from a peer, a different motivation, and that's great, obviously, and they can help check in with people after they've left the facility. The other thing that we've noticed from our recovery coaches is how they've injected confidence and optimism about treating addiction into our staff. Because now, again, our emergency department staff can say, well, I know a little bit about treating this condition, but we've got somebody else here who's super cool, who I like a lot, and who is an expert. And so now the emergency department teams are really feeling empowered to do something in a way they didn't before. And it's interesting because what we've noticed is even now when there isn't a recovery coach immediately available, the fact that they've been there has injected this confidence into the emergency department staff, so they seem to be more willing to have conversations on their own. Said we're now offering buprenorphine in the emergency departments, and part of the willingness of our emergency department staff to kind of say, yeah, we can do this, is the fact that having the recovery coaches side by side has really sort of said, oh yeah, we can do this. This is just like all the other work we do, but a new health condition. Sure, we can do this. It's been really a system enhancing project, having the recovery coaches, as well as obviously enhancing the care of the individual patients who the coaches happen to touch.
So you're a team now.
Yes, we are a team. There's the nurse
You know what
case
that
managers.
means, right? Together, everyone accomplishes more.
Yes.
And it's great that if each person knows a little bit about each other's job, and it helps.
Yeah. And it's I feel like we've got a sense of optimism about this condition.
Yes, yeah, it's great to see that everybody's so optimistic about helping people. You know, instead of a day-by-day job, oh, I'm just going to do my job and I'm going home. You know, there's a lot of dedicated people that are willing to help with addiction, and I love that.
There is one thing I'd like to add too, because I think we learn as much from people like you, Joanne, committed. You spend every night of the week out in some way advocating, supporting other people in their programs. But we learned so much from the mothers, from people in recovery, and we take that information back to Cambridge Health Alliance, and it's very gratifying to be part of the community meetings.
Right.
And it is a huge network that you know you can turn to for everything. So I just want to add that we're as grateful and considerate that, you know, it goes.
We all need each other.
Yeah.
We all do. I mean, there's a lot of parents that are out there who have lost their children. Not only lost their children, but others that are still dealing with addiction, that always feel alone. They don't, whether it's, you know, don't be ashamed, don't be embarrassed. It's not. It's something that happened. That opioids are addictive, and unfortunately, sometimes your child is because of peer pressure is using opioids, and not that they had an injury that put them on opioids. You know, it's okay. Let's just take care of the situation, and let's not worry about what other people think. You know, let's take care of our children and keep them alive. You know, that's my main goal. And because they matter. We all matter.
Yeah.
You know?
Yeah. It's interesting having these conversations with the emergency department as they're learning more about this condition and getting more comfortable with treating it, that the frame of reference has just changed, and some of this is unfortunately the reality of fentanyl on the street these days, is, you know, when you're an emergency department staff member, their job is to be in the moment. Their job is to make sure somebody lives to get out of their emergency department, go home to their family, and eventually make it to whatever stop there is going to be their next stop in the healthcare system if they need more help. And it was interesting. It took a little time, but they got there for us to be able to say, you know, if you give somebody medication to treat this illness in the emergency department, you know they're more likely to be able to go home tonight, not inject heroin, wake up tomorrow, go about their daily life, and move forward. And being able to frame offering medication as this is a life-saving thing you're going to do for somebody today, really put it in sync with the way the emergency department views their work. Our work is to save lives today. Okay, well, you know, give somebody medication for opioid use disorder. Like, you've now saved their life today. Whereas, and that was kind of the culture change we had to work on in the emergency department. Other parts of the healthcare system, the culture changes were different. You know, in primary care, we sort of had to do this work of, this is a chronic condition. You know, I'm a primary care doc. Give me diabetes, give me hypertension. This is my bread and butter. Any of my colleagues would say the same. We treat chronic diseases. Okay, so now we get used to the idea that opioid use disorder is a chronic condition, that it requires a combination of medication and behavior change. Okay, I do that every day with my patients with diabetes and hypertension. Okay, this is what I do now. But so the culture change in the healthcare profession, different in different settings, but it's, again, these are conversations we're having, these are issues we're paying attention to and really working on. So we're not totally there, but we've made a lot of progress.
You have. I've witnessed it. But I wanted to talk about, like, when someone comes for help, do they always see a psychologist? Do they always, I mean, is that a part of the total health care? And remember, I was talking to you about a situation where someone has been on methadone for many, many, many years. I'm saying at least 20 years, and the doctor and the psychologist is always talking about drugs instead of helping them achieve other things like a job or a hope. They don't want to go to the meeting. They don't want to have. They don't want to go to the psychologist anymore, go to these meetings, because it's always the same subject, and it's disheartening to them. So maybe that's one area that we can change.
Yeah.
Maybe give them more education on how to deal with the patient. So that's the latest thing that I see as being a problem right now. Other than that, I would love to have you be my doctor.
I think you have an excellent one. Who's one of my colleagues.
I do.
Can't
She
disclose.
is excellent, believe me. I do know that.
But you know, it's different strokes for different folks, and different strokes as different stages of their treatment needs. So you ask, does everybody see a psychologist or a mental health professional? The answer is it depends, because some people need that extra help, and some people don't. And what I can generally say, both from my experience now, having done this work for a while, but also knowing a bit about the science about it, is people do best in recovery if they've got some structure about their life. I mean, as adults, I don't know, we were sort of meant to do things, whether it's family care, elder care, child care, job, volunteer, church. I don't know. We were meant to be active participants in life. And so to help somebody be in solid recovery, they need that stuff. And so part of my job is to help them figure out what that stuff is going to be for them. And again, it's going to change. It could be that early on, well, we know you're more likely to pick up cocaine when you get bored. So we got to really figure out ways so you just don't get bored. And we'll come up with a schedule of activities or groups or whatever.
It's up to the individual, because, for many, many years, I've always been in the community. And for 11 years, I was in the Pop Warner program. So I dealt with parents, coaches, 275 children. And when I left, I was depressed because I was so used to being active that I had to find something else. So I always find, whether it was needlepoint or painting or dancing or singing, I do that. You have to do more so that you can fix yourself. I mean, that's probably not the right term, but it's like we all need more than what we have, and every day we should try to improve our lives in some way. Whether it's to read a book, because now they're introducing that as well with recovery, yoga, meditation, go to the gym. A lot of people need to get that hostility and frustration out. So they go to the gym every day. These are great things.
We haven't yet figured out a way to get people to pay for all of it. Because yes, I would love to say Mass Health is going to pay for a gym membership, at least in the winter months in Massachusetts, so that my patients can be active.
Yeah, we have this. We get very, very, what do we get without sun?
Vitamin D deficient and basically, yes, exactly. seasonal affective stuff.
Then we have jogging. We have walking.
Yes, no, and there certainly are ways you can get exercise, do things.
But a lot of places are starting to introduce that. I know a lot of treatment centers. They have those facilities inside their treatment centers. So if you want to go and you can work out. Did you want to add something, Mary?
I was going to say, we have, before Mary nudges me, I'll say at CHA we have yoga. Actually, and it's only $1 a class if you get a referral from your doctor. My patients who've gone really like, we offer it at several different sites in our system. They really like it because, for one thing, it's $1 a class, which is a better deal than anywhere else. But also, it attracts a different clientele than what people may imagine as the cool young people in their sculpted bodies at their yoga class.
See that's for sure. I'm old. It's never going to come back.
Exactly. So come to CHA for yoga, and you'll have bodies like yours there.
No, actually, I did go to CHA many, many moons ago in Somerville, and they had yoga classes, and the city of Somerville food service paid for it. You know, and you know, it was enjoyable. A lot of my friends, well, a lot of my co-workers, we had fun. You know, and it worked. And we one time we walked around the city and looked at the trees and how it's budding and everything else. Things that you don't look at normally because you're too busy. But to look at all these things around you, the birds, trees.
Yeah, no, one of my colleagues in Somerville is in the psychiatry department is doing a research study specifically using mindfulness and that whole idea of in the moment, just focus on you and your breath as explicit part of treatment for opioid use disorder. And actually has federal research money to study that right now at several of our sites.
That's really great.
Yeah.
Do you know that we have only one more minute left? We actually spoke for an hour, and you are such an enjoyable guest, and I've learned a lot from you.
Good.
And if anybody that needs help, go see Ellie Grossman. She
Or
has availability.
Or any of our Cambridge Health Alliance primary care sites. You walk in the door, you call Dr. Finder, and you say you want help. We gotcha.
I'm so happy. I am so happy I had you on, and we'll have to have another night that you come and visit again.
It's been a pleasure.
And you'll give us more information on more changes to improve the system. Thank you.
Thank you.
Yeah. Did you hear my squeaky chair? No, we're not off yet. We still have like 8 seconds, and then the show will end. But why don't you get up and wave, Mary?
Nice, comfy, cozy type.
You got it here.
Oh, right here.
There you go. Oh, no,
there you go. Excellent.
I like being off duty. But I enjoyed the show.
Thank you. And you know, we're actually off now. But I wanted to, you know, it's great. A lot of times that we've been having those more meetings. I mean, it's always beneficial for us to learn about. I mean, even the recovery center that we're trying to get into Malden. CHA has done a lot of work with that, and it's wonderful because I wanted it here in Somerville, but unfortunately we weren't going to get the support as. No, but I really, that Mayor Christensen is amazing that he just went right in there and said that. Yeah.
And you know, they probably, Joanne, have a little more open options.
Space-wise.
Space-wise, Somerville is. I did the Summer Vision meeting yesterday. I'm on the Summer Vision committee doing affordable housing, and we hosted at the Armory, and you know, people were talking about the density again. Although I reminded them when I was a kid growing up in Somerville, that you know, 101,000 people lived in Somerville. We got as low as what, 75,000 for a while, and that was probably because behind that, you couldn't cut through.
I haven't shut that off. It's
Yeah.
still on YouTube.
Oh, you know what?
I'm supposed to, but
Nice doing
That was
you.
good, great job.
That's
I
fine.
tell you, that went by so quickly.
I was gonna say, I can
One
talk about this,
sign of a great-
I can
yeah,
talk, I can
yeah.
talk about this stuff for a while.
I think we do need to start building though. I mean,
Well,
we need, we're all talking green
Yeah.
space, green space.
Yeah.
I understand that, we need trees, we need
Yeah.
to put them on top of all these
That's what we were
buildings.
talking about.
I'm sorry.
That we have to be creative and, what else we talked about? People realize that,